People think of sleep apnea, middle-aged man that's overweight or obese and who snores loudly and falls asleep during the day. Women tend to present quite differently. Instead of having sleepiness per se, may complain more of fatigue, frequent wakenings, insomnia, night sweats, morning headaches, symptoms that often get attributed to menopause or thyroid disease.
Many times when a woman will come to me, again, very similar to the symptoms, very kind of non-descriptive symptoms, usually there is a delay, potentially of several years of dealing with this. We do a test, and then I notice while their numbers overall look relatively, quote, mild, I'm looking at them being very symptomatic in terms of how their quality of life has declined as a result.
Hello and welcome to Sleep is My Waking Passion, the podcast where we get real about sleep and how it shapes your life. I'm Dr. Alison Kole, a triple-boarded pulmonary critical care and sleep medicine physician who's learned to thrive despite having chronic insomnia. And now I'm here to help you do the same.
Hello, everyone, and welcome to another episode of Sleep is My Waking Passion, the podcast where we get real about sleep and how it shapes your life. I'm the host, Dr. Alison Kole, and today I have an even cooler guest than I could possibly have imagined, Dr. Nancy Collop. And I know folks listening are be like, okay, what's so special about this woman? Dr. Collop has been literally one of the most distinguished voices in sleep medicine. She carries with her a world of expertise. And I've really learned a lot from her, even just sitting in sleep trends. I was sharing with you, Nancy, from many, many moons ago has really shaped some of the things that I did in my career. She has served as the 26th president of the American Academy of Sleep Medicine. She has been editor-in-chief of the Journal of Clinical Sleep Medicine, and she currently directs the Emory Sleep Center, where she holds professorships in both medicine and neurology. She is recognized as a Master Fellow of the American College of Chest Physicians and received the prestigious Nathaniel Kleitman Distinguished Service Award for her extraordinary contributions to a field of sleep medicine. What I'm really, really excited to explore today with Nancy is really sex and gender differences. That can be across all sleep disorders, but today we're going to focus it on something that is incredibly common and incredibly underdiagnosed in women. So welcome, Nancy. It is so exciting to be able to speak with someone who is so passionate about moving the needle on sleep health in this country.
Thank you for that lovely introduction.
So I guess what I would like to start off with is when we're talking about obstructive sleep apnea in women, can you just describe for my audience just how significant and large this problem really is? Like, what is the true burden? And why do you think that we are just missing the needle and getting women diagnosed?
Yeah, so there's been a number of studies that kind of look at the prevalence of sleep apnea in general and in between the two genders. And in general, sleep apnea is probably a little more common in men than it is in women overall. But when you look at women after menopause, the prevalence is, the likelihood of having sleep apnea is about the same in men and women. So menopause is kind of a triggering factor for the development of sleep apnea in women. And as far as how prevalent it is, again, some of the studies, it depends on how you define sleep apnea, but the burden is pretty high. It's, probably at least 10% of the population in general, again, depending on how you define sleep apnea. So it's a real problem. And one thing I'll mention about the difference between men and women, I know we'll get into that a little bit more, but we know that even though prevalence is a little higher in men, women tend to use up more healthcare costs associated with sleep apnea. So even though they don't have as high a likelihood of having sleep apnea, the costs related to that are higher, probably due to underdiagnosis.
Do you think there are certain contributing factors to that underdiagnosis? One in my mind is just the different clinical presentation. Maybe we could kind of talk about the differences between how women might likely present versus men. There's some overlap there, but I definitely think some of the symptoms that women tend to complain about tend to be poo-pooed or not associated with sleep apnea when perhaps they should be stronger linked.
Yes. So in general, people think of sleep apnea, kind of the classic sleep apnea is a middle-aged man that's overweight or obese and who snores loudly and falls asleep during the day. That's kind of the classic presentation. But in fact, in my clinics, that's not the usual person I see. So particularly in women tend to present quite differently, and it's probably because we sleep differently. So women, instead of having sleepiness per se, may complain more of fatigue or frequent wakenings, insomnia, night sweats, morning headaches. And so those are very kind of generic symptoms that often get attributed to, menopause or thyroid disease or all different kinds of things. And so the presentation in women will often look different in men. And because of that, it often gets put off for a number of reasons while they look into other things, depression, all different kinds of things that, and that are often related to sleep apnea, but attributed to other things.
One of the things that I have read and I've definitely seen, and again, granted, I've seen it in men too, but there's many times when a woman will come to me, again, very similar to the symptoms, very kind of non-descriptive symptoms. They've talked to their doctor about hormone replacement and blah, 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 but then they're coming to finally see me. Usually there's a delay, potentially of several years of dealing with this when they're finally coming. And we do a test, and then I notice that while their numbers overall look relatively, quote, mild, right? I'm looking at them being very symptomatic in terms of how their quality of life has declined as a result. But also this component of what we call REM-related sleep apnea, where we have non-rapid eye movement sleep and REM sleep. And then as we get into rapid eye movement sleep, when our airway tends to be more, our muscles are more relaxed and paralyzed, in fact, that we tend to see more events occurring. Can you talk a little bit about that? And do you think that factors into any other issues related to their cardiovascular disease risk as a result of that?
Yeah, that's been pretty well established that women tend to have more REM-related sleep apneas. Just for baseline, REM sleep is, there's two different kind of major types of sleep, REM and non-REM. And REM actually stands for rapid eye movements because we can see rapid eye movements occurring during that level of sleep. We spend about 20-25% of the night in REM sleep, and REM tends to occur every 90 minutes or so, but each period of REM gets longer as the night goes on. So you tend to have more REM sleep in the latter half of the night than in the beginning of the night. REM is really defined by the eye movements and, as you noted, the lack of muscle tone. So our muscles, our skeletal muscles, become essentially paralyzed during that type of sleep. And what that means includes the muscles in your airway. Now, one muscle doesn't become paralyzed in REM, that's your diaphragm. So you keep breathing, which is so you want to keep breathing when you're asleep. But the other muscles they're at their most relaxed state of the entire 24-hour period that we're alive. So REM sleep is very unique, and it's thought to be that's when we'll have our most memorable dreaming. You probably dream in other levels of sleep, but REM sleep seems to be associated with the most recall of dreams. And the other thing that happens in REM sleep, lots of things, but the other thing that happens is your sensitivity to oxygen levels are reduced. So your oxygen levels are allowed to go to even lower amounts during REM. I'm not sure why that evolutionary work like that, but that's what we know. So in women, what I like to say is men become more like men in REM. So what happens in REM sleep is women in general tend to have smaller airways. In general, their ability to keep the airway open in non-REM is better than men. But in REM sleep, because of that lack of muscle tone, in women, they become more vulnerable. Again, because the muscle tone goes away, they have a smaller airway. The other thing that happens is women tend to be more prone to awakening from sleep when there's an interruption in their breathing in non-REM. But again, in REM, because your sleep is somewhat deeper in women and men, that also goes away. So what happens in REM is the smaller airway is able to collapse easier. The oxygen level we're not as sensitive to it, and so we have longer drops in our oxygen level, and we tend not to have that arousal response that we have in non-REM. So that's why women tend to have more REM-related apnea. I guess these disruptions in your sleep or disruptions in your breathing that occur in REM also cause a surge in your sympathetic nervous system. That then causes more abrupt changes in your blood pressure, There's a phenomenon that occurs when you sleep where your blood pressure goes down. It's called dipping. And so in people that have REM-related apnea, they tend to lose that, which seems to also be a risk factor for stroke. The REM-related apnea has also been shown with development of high blood pressure and cardiovascular disease. So all these things go together to seem to make REM sleep a very vulnerable part of sleep, and particularly, with regards to obstructive sleep apnea.
And can you talk a little bit about how hormones may influence this whole pattern?
Yeah, clearly that's an issue because of the whole postmenopausal thing. So there's lots of literature out there that's looked at the effect of, dropping estrogen levels and progesterone levels on cardiovascular disease risk, immune system function, etc. I mean, the immune cells have estrogen receptors, and so as estrogen goes down, it may have an interaction with your immunity because of that. It also, the lack of estrogen and progesterone seem to have effect on the muscle stability in general. As those hormone levels go down, the muscle becomes, including muscles in your upper airway, become more unstable. The other thing that happens in menopause that probably has some effect in some women is there's an aspect of weight gain, which also increases the risk for sleep apnea. Aside from sleep apnea, after menopause, sleep becomes more fragmented. And so that probably also kind of exacerbates the symptoms of sleep apnea that women have, because not only now do they have poor sleep, but they have breathing issues that occur during sleep.
If there are women listening to this and going, I kind of know my sleep is crappy, but I've always attributed it to X, Y, or Z. What's the threshold or barometer upon which a woman should be more proactively advocating or being interested in some more formal testing to better assess what's going on with their sleep? Do you have any guardrails? Because you can think of it many ways, right? We could look at it like, as you mentioned, 10% of the population probably has some form of sleep apnea. There's roughly 300 million people in this country. So that would be 30 million people. There are, less than 10,000 board certified sleep providers, for example. So if you're looking at an access standpoint, it's like, well, if I tell every single person to go get tested, then that just jams up the system. But are there any sort of real red flag type items where you'd say, I really think you should be prioritizing this, even if you've been told that it's just a natural part of aging, for example?
Yeah, well, there's a few things. I think certainly if you have any what we call comorbid illnesses, so diabetes or high blood pressure or heart disease, and you have issues with your sleep, that should at least be a signal. I mean, just in general, if you go into high blood pressure clinics and test people for sleep apnea, about a third of them will have sleep apnea. If you go into clinics where there's what we call resistant hypertension, so people that take at least 3 blood pressure medicines to control their blood pressure, the level of sleep apnea is way higher. It's like 70%. So certainly that would be something that you would want to think about sleep apnea. The other thing is women tend to probably be a little more aware of their bed partners than their bed partners are aware of them. And they can talk to their bed partner about my snoring, or do you notice that there's any gasping, or that I seem to hold my breath. Women, again, tend to want to downplay snoring, thinking it's not ladylike or whatever, but it certainly is very common in sleep apnea. Like I say, most everybody has sleep apnea snores, but not everybody who snores has sleep apnea. But it is definitely something to be concerned about. And then there are other disorders that, like I mentioned, diabetes, polycystic ovarian disease is another one where women have a really high prevalence of sleep apnea. I think the most important thing is if you're not getting good rest and you're not sure why, it's definitely worthwhile to talk to your doctor about it. Sleep apnea should always be on the differential. One of the challenges with sleep apnea, as I tell people, is you have it when you're asleep. So you don't know that you have it, right? I mean, I've had people who I do their sleep study and I show them the results and they still don't believe that it's them. That's the big challenge with what we do, is people have this while they're asleep, so they are unaware. And so a lot of times how people end up coming to see the doctor is because somebody else has noticed a problem with their sleep, or, there's just this lousy sleep that they finally get fed up with and say, okay, maybe it's more than just menopause.
For our providers who are hearing these complaints, let's say we do discover that the patient ends up having some mild sleep apnea. A woman is presenting and they say, oh, these numbers this AHI business doesn't look so bad. It's probably going to be a primary care potentially that has ordered a test and is getting these results. What advice in terms of how we counsel patients would you give that provider? Because I think underscoring this discussion is that women, you can have something on paper that doesn't, quote, look that bad. But again, if you're dealing with someone who gets pretty bad in REM, for example, as you mentioned, this REM-related sleep apnea that women are more associated with, that portends potentially a much higher cardiovascular risk than meets the eye. Is there a discussion around that you would want providers to understand, and even any future potential patients or listeners to understand that are non-medical, about that link to cardiovascular disease and sleep apnea in women?
Yeah, sure. The severity of sleep apnea is defined by the number of breathing events you have per hour. That's basically how we define how bad somebody's sleep apnea is. It's very simplistic. So we look for breathing events that are defined a specific way, and then we add those all up at the end of the study, divided by the amount of time either that the test ran or that you were asleep, depending on what type of study, if you had a home study or a lab study. And so it's called an apnea-hypopnea index. So you add up all the apneas, all the hypopneas, and you come up with this index of number of events per hour. It's very simplistic. It has some associations with something, but it's not really well correlated with a lot of things. And so sometimes I feel like saying, oh, because your AHI number is between 5 and 15, that means you have mild sleep apnea. It really doesn't always portend that that's not related to the symptoms that you have. So in other words, I've had patients who have mild sleep apnea by our definition and are extremely impaired by it. And some of that probably relates to how impacted somebody is in general by poor sleep. And we all have different tolerances to poor sleep. And so a doctor seeing AHI of 5 to 15 saying, oh, that's mild, well, then it's probably not the reason for your symptoms. I don't think you can say that because it's not a one-to-one correlation with the mild and the symptomatology. So in general, what I tell people is the patient came to you for a reason. There was some complaint that they had, usually that's how they end up in your office. And you get this test in, it's abnormal. It may not be severe, but it's abnormal. And as you mentioned, women tend to have less severe apnea. I think it's, a conversation you have with the patient about maybe we should treat this. And in general, the treatments for sleep apnea are not that bad. And in other words, they're not going to hurt you too much. The most common treatment is nasal CPAP right now, which is a airway pressure device, a little mask you wear, and it blows air into your lungs and the air pressure keeps your throat open. The other one is like a mouthpiece that you wear, and it pulls your lower jaw forward a little bit, to help open up the back of your throat. While they're inconvenient, they tend to be pretty benign therapies, and so a lot of times my conversation with a patient will be, well, this is what we have, and it's worth seeing if treating your sleep apnea makes your symptoms better, particularly in those cases of milder disease. There's also other treatments that are out there, like now weight loss. We know there's new weight loss drugs that are kind of revolutionizing medicine in general. One of the indications for at least one of the drugs, tirzepatide, is sleep apnea. Weight loss helps, and then probably sometime there's going to be a pill soon for sleep apnea that's going to come. So I think, I wouldn't necessarily always focus on the degree of sleep apnea, particularly maybe in women more so than men, because it's not a correlation necessarily with the symptoms. And it's particularly, important. And people that I do slightly have as comorbid diseases, like you mentioned, they're probably a higher risk for cardiovascular disease. So we might want to be a little more aggressive in those patients that have high blood pressure, diabetes, or history of heart disease, even if it is mild apnea. because of that.
Thank you so much for that, Nancy. As we wrap up, what I wanted to ask you, with the years of experience that you have,
Well, you make me
very no, I mean, no. This is like, it's fine wine.
for a long time.
Like, but like you have a glimpse of a history of just sleep medicine in general, that someone such as myself, I've got, a little over a decade experience in sleep, and you've got a longer experience in sleep. So with your expertise, I'm curious as to where you think things are going to go in the future with sleep. What do you see being on the horizon for us? This doesn't have to be specific to obstructive sleep apnea or women's health, but if you have any little nuggets to get people excited about what they can expect, and it's related to that, please have at it.
Oh yeah, I've seen a lot of changes over the 40 years that I've been doing this. I think there are some really interesting things that we're going to see, and we're already starting to see. So one is the wearable technology. So wearables, neurables, all these things that now are assessing our fitness, our sleep, our diet. I mean, all this is, some people may call it intrusive, but what it has done is, at least in the last few years that I've been noticing this, is it has made people more aware about their sleep. Because in the past, I feel like people thought, well, I'll sleep 4 or 5 hours and that's enough. But now when you're actually quantitating it and seeing it and correlating it with how you feel, I think the wearable technology has raised the awareness of sleep in general and as a part of health. And so I'm hoping that, that will not only continue, but get better over time. And it's also going to, and it already has, really start to help screen for disorders like sleep apnea. So, some of the watches now have a sleep apnea detection. And again, they're not going to take the place of doing a sleep study, a more formal sleep study yet. But they're actually going to, at least if you see this come up on your watch, like, hey, you may have sleep apnea, then, you can take that to your doctor and say, hey, my watch is telling me this. Should I pay attention to it? So again, I think, and it's not, like you said, it's not just for sleep apnea, it's for other sleep disorders potentially as well. So I think that technology is really exciting. And I think our diagnostic technology is going to get, better as well. One thing that happens right now, which, doesn't need to, is that, when we do a sleep study, we do one night. And, that may be a good night, but chances are it's not going to be the best night of sleep you ever had. So this wearable technology, as it becomes less and less intrusive, will allow us to study people over multiple nights. And, we'll get a better idea of, if you have a really bad night, again, going back, not to regress too much, but going back to women that have REM-related apnea tend to have that later in the night. Let's say you have a really bad night's sleep and you don't hit a lot of your REM because it comes later in the night. That you may be mis or underdiagnosed because of that. So I think being able to, diagnose multiple night diagnoses. Right now, it's one night and that's all that, is reimbursed. So hopefully that will improve over time. And then the other exciting thing are just the interest in sleep and new treatments that are coming out. So treatments for narcolepsy and hypersomnia disorders, treatments for sleep apnea, treatments for obstructive and central sleep apnea. I mean, there's all kinds of new technologies coming out that I think are really exciting. And really in the last, I'd say 5 years, those have probably been more than what we had the 25 years before that. So, yeah. I mean, it's just exploding. And so I think this interest in sleep has gotten into the industry as well. And so I think it's a really exciting time to be involved in the sleep field. And I hope that more physicians will pay attention to their patients' sleep. As a sleep doctor, that's always been one thing that's been frustrating, is the amount of time that's dedicated to sleep medicine in medical schools and residencies has never been enough, I believe, for, something that people spend a third of their life doing. We should probably pay more attention to it. And health providers should as well.
I think those are fantastic final words. The one thing that I like to kind of reiterate to HCPs, if I'm giving a talk anywhere, and I know that they're kind of in the internal medicine world and they're getting of course, they're getting onslaughts of patients who may have 5, 10, you're trying to triage what the most important thing is. But one of my parting words is, if your patient bothered to spend any amount of time mentioning that their sleep is crappy, most of the time that patient has been thinking about their sleep for a while, but has been like, well, they're kind of managing my cholesterol and this and that. And do I really bring it up? I have so many patients that are like, that's the last thing on their bucket list is to mention sleep because they're have all these other medical issues and they think the doctor's not going to want to hear about it. So I try to say, just that fact that they flagged this for you is a step in the right direction for you to say, even if I'm not quite sure how to answer these, and I think that sometimes is a barrier, that feeling like I don't really know what to say, forge that relationship and get them to see a sleep specialist. Like just say, listen, I know someone who can answer these questions, even if I don't have all the answers for you. Let's make that connection. I think that can be hugely helpful in kind of moving the needle. Because usually, I don't know about you, but patients are typically like, it's the hand on the door philosophy. Like, hey, is there anything else? And you're just about to leave the room and they're like, by the way. And often sleep is the by the way kind of remark.
Yeah. Well, I do think more primary care docs are at least included in some of their intake information for patients. So it's getting there. It's like I said, it's better than it used to be for sure, but it's still got a ways to go.
Well, I appreciate so much your time and your expertise. Thank you for sharing it with me. And thank you, quite frankly, for sharing it with the entire audience in the world. It's going to be out there for everyone to hear. So I appreciate you.
Thank you very much. I appreciate it.
Struggling with sleep? Dr. Kole is here to help. Whether you need a comprehensive sleep coaching program, suspect you have sleep apnea, or simply seeking a second opinion, she's available for consultation in New Jersey, New York, California, and Georgia, with more states coming soon. Schedule your free 10-minute review of services today to find out which visit is right for you at AskTheSleepMD.com and start your journey to better sleep with a trusted sleep expert.
Please be advised that the Sleep is My Waking Passion podcast is for entertainment and educational purposes only. It does not constitute medical advice. Always consult your healthcare provider for personalized guidance. For my full disclaimer, please visit AskTheSleepMD.com, and while you're there, don't forget to sign up for my free newsletter. Sweet dreams and happy listening.